What I'm about to walk you through is going to permanently change how you look at every blood pressure pill sitting in your medicine cabinet. Because if you are currently taking Amlodipine, Losartan, or Lisinopril, there is a very real possibility that one symptom you have been writing off as stress, poor sleep, advancing age, or simply a rough week is actually your body sending you a warning signal that your medication is affecting you in a way nobody fully spelled out. And that is the part that keeps me up at night. Because people do not typically get harmed by these drugs when they are incorrectly prescribed. They get harmed when they do not understand what the medication is actually doing inside them, and they overlook the signs until something serious has already happened. Before we go any further, please subscribe to this channel so you never miss the kind of clear, practical health guidance that is designed to protect you. My name is DR.Michonne, and if you have been instructed to take Amlodipine, Losartan, or Lisinopril to bring your blood pressure under control, there are 11 things you need to understand right now. Not because your physician is withholding information from you, but because most appointments are too compressed, most explanations are too rushed, and most patients walk out with a prescription in their hand and only a fraction of the information they actually need. By the time we are finished here, you are going to know which side effects are routine, which ones are genuinely dangerous, which ones sound trivial but absolutely are not, and why the most critical truth in this entire conversation has nothing to do with the number on your blood pressure monitor, and everything to do with whether you can remain on the medication safely over the long term. Let me start with Gloria, because her story captures exactly why this conversation is so necessary. Gloria was 72, organized, diligent, the kind of patient every clinician is grateful for. She took every dose precisely as instructed, kept every follow-up appointment, and never once skipped a pill. Her blood pressure responded beautifully. On paper, everything looked ideal. But 3 months in, she was sitting across from me explaining that her shoes no longer fit properly. Her ankles looked swollen every evening. She felt strangely heavy by the time she went to bed. She assumed she was gaining weight. Her daughter was worried about her heart. Gloria was genuinely frightened. And what no one had taken the time to clearly explain to her was that the medication doing exactly the right thing for her blood pressure was simultaneously producing a very specific side effect, one that fools people into believing something else is wrong entirely. Which brings us to number 11. Number 11. These 3 medications are not interchangeable pills wearing different labels. Amlodipine is a calcium channel blocker. Losartan is an ARB, an angiotensin receptor blocker. Lisinopril is an ACE inhibitor. They all reduce blood pressure, yes, but through entirely different mechanisms, which means they each generate entirely different patterns of side effects. If you do not understand that distinction, you will misread what your body is communicating. You will assume all blood pressure medications behave identically. They do not. Amlodipine relaxes blood vessels in a way that commonly produces swelling in the lower legs. Lisinopril is well known for triggering a dry cough. Losartan is frequently selected as an alternative when that cough becomes intolerable. Same therapeutic goal, different biological pathway, different warning signs. And here is why that matters more than most people appreciate. If you develop a cough on Lisinopril and conclude that all blood pressure medications will produce the same effect, you may abandon treatment entirely. If you swell on Amlodipine and assume your heart is deteriorating, you may spiral into unnecessary panic. If you feel perfectly well on Losartan and assume there is nothing to watch for, you may miss a potassium imbalance developing quietly in the background. The first hidden truth is this. The name on the bottle tells you the drug class, and the drug class tells you the pattern. Once you understand the pattern, your body stops surprising you, and once it stops surprising you, you make better decisions faster, which can prevent a manageable side effect from escalating into a genuine medical emergency. Number 10 is the exact situation Gloria had been living through without realizing it. Amlodipine can cause ankle and leg swelling, and this swelling is among the most misunderstood side effects in all of blood pressure medicine. People attribute it to eating too much salt. They think their kidneys are weakening. They assume they are becoming less active and accumulating weight. But with Amlodipine, the swelling frequently occurs because the small arteries relax more aggressively than the veins do. blood flows into the legs more readily than it returns. Pressure accumulates in the smallest vessels, and fluid begins seeping into the surrounding tissue around the ankles and feet. This is why people often describe it as, "Fine in the morning, but by evening my socks are leaving indentations." Consider Arthur. Arthur was 76. Every afternoon his ankles appeared noticeably larger than they had in the morning. He chalked it up to getting older. He started propping his legs up at night and observed that the swelling eased overnight, only to return as the day progressed. He never connected it to the amlodipine he had started 6 weeks prior. What made this genuinely hazardous was not the swelling itself, it was the silence surrounding it. He did not want to burden his doctor. He kept taking the medication. He grew increasingly uncomfortable, and eventually he began skipping doses on days he wanted to leave the house because he was embarrassed by the appearance of his legs. That is precisely how a manageable side effect transforms into uncontrolled blood pressure. The swelling may not mean the medication is permanently wrong for you, but it absolutely means a conversation needs to happen. Number 9 is something patients dismiss for far too long. Lisinopril can produce a dry, persistent, maddeningly stubborn cough. And what physicians often fail to emphasize is that this cough does not necessarily begin immediately. It can surface within days. It can appear after several weeks. In some cases, it arrives after months on the medication, which is precisely why people miss the connection entirely. They blame seasonal allergies, household dust, acid reflux, a cold that will not fully resolve, or dry winter air. The cough typically feels scratchy, irritating, and relentless. Not wet, not productive, not dramatic, just incessant. And because it frequently intensifies at night, people assume their lungs are the problem, when the actual source is the pill sitting quietly in their morning routine. Helen experienced this firsthand. She was 69. 4 months after starting Lisinopril, she developed a persistent tickle in her throat that would not relent. Then came the nighttime coughing episodes. Her sleep fractured. Her energy collapsed. She began waking up depleted every morning and assumed she was simply aging or that her reflux had resurfaced. She purchased throat lozenges, changed her laundry detergent, replaced the air filter in her home. Nothing helped. When I asked her to correlate when the cough began with when she started the medication, she looked genuinely stunned. No one had ever told her that the lisinopril cough can emerge weeks or even months after beginning the drug. The moment I explained it, everything fell into place. This matters because many patients silently endure that cough for months, and a significant number eventually discontinue the medication on their own without informing anyone. That is precisely the outcome we need to avoid. But there is something far more urgent embedded in this, and I need you to hear it clearly. A dry cough on lisinopril is generally not the same thing as a dangerous allergic reaction. The symptom that should genuinely alarm you is swelling of the lips, tongue, face, or throat, particularly if swallowing or breathing becomes difficult. That is not a situation for watching and waiting. That is not a call the office on Monday situation. That is, go to the emergency room immediately. ACE inhibitors like lisinopril can, in rare instances, trigger angioedema, and it can become life-threatening with alarming speed. ARBs like Losartan carry a rare but similar risk. But the primary concern is with ACE inhibitors. So if I say cough, do not panic. If I say tongue or throat swelling, that is the moment you move without hesitation. Number 8 is one of the most dangerous truths in this entire video because it hides in plain sight on grocery store shelves. If you take Losartan or lisinopril, potassium is a topic that demands your full attention. Most people hear that and think, I do not take potassium supplements, so I am fine. That assumption is incorrect. Potassium does not arrive only in supplement form. It is present in salt substitutes, heart-healthy seasoning blends, electrolyte powders, certain meal replacement products, and dozens of over-the-counter items people reach for without a second thought. Both Losartan and lisinopril can elevate potassium levels, and elevated potassium can become dangerous because it disrupts the electrical rhythm of the heart. It may not announce itself dramatically at first. It may present as muscle weakness, cramping, tingling, fatigue, palpitations, or, in some cases, almost no symptoms at all. Consider Robert. Robert was 74 and was genuinely committed to his health. He reduced his sodium intake, began reading ingredient labels, and switched proudly to a salt substitute because he believed he was doing precisely what his heart required. What he did not realize was that most salt substitutes replace sodium with potassium. So here was Robert taking Losartan, a drug that can raise potassium, and simultaneously seasoning every meal with additional potassium on top of that. He began feeling weak and vaguely unwell, then noticed intermittent irregular beats in his chest. By the time his lab work was reviewed, his potassium had reached a level requiring immediate attention. The tragedy is that Robert was not careless. He was conscientious. He was trying to follow the rules. No one had simply drawn the connection for him. That gap in education is precisely where patients get hurt. Number 7 is the truth about kidney numbers, and it confuses people so thoroughly that some discontinue their medication at the exact moment it may be offering the most protection. Losartan and Lisinopril are not purely blood pressure medications. In the right patient, they can actively protect the kidneys and heart over time. But when you first begin taking them, or when the dose is increased, your physician may check blood work and observe a modest shift in kidney function, perhaps a rise in creatinine or a slight decline in eGFR. To many patients, that looks like proof the medication is damaging their kidneys. Occasionally, that concern is valid, but often a small, early change is entirely expected because these drugs alter the pressure dynamics inside the kidney's filtration system. That is precisely why follow-up blood work matters, and why drawing conclusions without guidance is so hazardous. Sharon came very close to making that error. She was 71 with both elevated blood pressure and early kidney disease. Her physician had selected Lisinopril specifically because of its long-term kidney protective properties. A few weeks in, her lab numbers shifted slightly. She saw the results in her patient portal before anyone called her, became frightened, and was moments away from stopping the medication that same night. When we spoke, I explained that the crucial question was not simply whether the number had moved. The critical questions were, how much did it move? What is the trend over time? And what else is the body doing simultaneously? A mild, anticipated shift under appropriate supervision is an entirely different clinical picture from a dangerous deterioration. Lab follow-up is not a bureaucratic formality. It is an active component of the treatment itself. Number 6 is among the most under-recognized dangers in older adults. Dehydration changes the entire equation. If you are taking Losartan or Lisinopril and you develop vomiting, diarrhea, a stomach illness, poor appetite, or significant sweating in warm weather, the medication that was helping you yesterday may behave very differently today. Your blood pressure can drop too low. Your kidneys can come under strain. You can feel dizzy, weak, or faint. In some cases, you can move into acute kidney stress far more rapidly than you would anticipate. The medication did not suddenly become harmful. The fluid balance inside your body shifted, and now the same dose is operating in a completely different internal environment. This is one of the most critical things no one explains, because people continue taking the same pills through illnesses that radically alter their hydration status. Frank was 78 when this caught up with him. He developed a severe stomach virus, could barely keep anything down, and still took his usual Losartan every morning because he was proud of his perfect adherence. That evening he rose from the couch. The room lurched, and he nearly hit the floor. In the emergency department, the problem was not that Losartan was the wrong medication. The problem was that his body had been depleted. He had lost too much fluid, his blood pressure had dropped dangerously, and his kidneys were under significant stress. What Frank needed was not blind loyalty to the pill bottle. He needed a sick day plan. He needed to understand that illness rewrites the rules, and that calling for guidance is not weakness, it is wisdom. Number 5 is a hidden trap sitting in millions of medicine cabinets, and it has nothing to do with prescription drugs on its own. Ibuprofen, naproxen, something grabbed from the shelf for back pain, knee discomfort, or a weekend of garden work. If you are taking Lisinopril or Losartan, particularly if you also use a diuretic, regular use of certain over-the-counter anti-inflammatory pain relievers can create a perfect storm for the kidneys. Each component seems unremarkable in isolation. A blood pressure pill, a pain reliever, perhaps a water pill. But combined, especially in the presence of dehydration, they can reduce blood flow to the kidneys and meaningfully raise the risk of kidney injury. And most patients never mention the over-the-counter pain medicine to their physician because they do not register it as a medication. It came from the drugstore. It feels harmless. Carol did exactly that. She was 73, took lisinopril for blood pressure, used a diuretic for leg swelling, and reached for ibuprofen several times per week for arthritis in her hands. She felt she was managing things well. Then her labs deteriorated, her blood pressure became erratic, and there was sudden confusion about what had changed. There was no mystery. It was the combination. Once the daily anti-inflammatory was removed, safer alternatives were identified, and her monitoring was tightened. Things stabilized. But here is what I need you to carry with you. Many patients believe medication dangers come primarily from rare side effects buried in fine print. In reality, some of the most significant dangers arise from ordinary combinations that no one has examined carefully enough. If you take Losartan or Lisinopril, over-the-counter pain relief is not a casual topic. It is a patient safety topic that deserves a real, direct conversation. Number 4 is the side effect people normalize until it ends in a fall. Dizziness, lightheadedness, that unsteady floating sensation when you rise too quickly, the weakness that accompanies the first few doses. With all 3 of these medications, particularly when initiating treatment or increasing the dose, your body may require time to adjust to a lower blood pressure. That adjustment can manifest as dizziness, especially during the transition from lying down to standing. People laugh it off. They say, "I just got up too fast." Perhaps, but in older adults, a few seconds of dizziness can become a fractured wrist, a head injury, or a broken hip. And here is what people consistently underestimate. Sometimes dizziness is the medication working slightly too aggressively for your current physical state, your current hydration level, or your current combination of drugs. Joseph was 80 and deeply proud of his independence. He lived alone, moved deliberately, and disliked asking for help. 2 days after his amlodipine dose was increased, he rose from the bathroom floor in the middle of the night and felt the room tilt. He grabbed the edge of the sink just in time. He did not fall, but it shook him badly. When I asked whether anyone had advised him to rise slowly, to pause at the edge of the bed before standing, and to monitor carefully for persistent weakness or near-fainting episodes, he shook his head. He had been told the medication might lower his pressure. He had not been told what that could actually feel like inside a real body, moving through a real house, in the dark. That is the difference between handing someone a prescription and genuinely preparing a patient. Mild dizziness may resolve on its own. Fainting is not something to rationalize away, and recurring dizziness is not something to silently accept. Number 3 is where many thoughtful, intelligent people accidentally undermine their own treatment. They observe one blood pressure reading, see a high number, and conclude the medication is not working. Or they see one low number and decide the dose is too strong. That is not how blood pressure functions. Blood pressure moves. It shifts with sleep quality, pain levels, emotional stress, physical activity, posture, meal timing, caffeine intake, and even the anxiety of taking the measurement itself. A single reading is not a verdict. It is a snapshot. What matters is the pattern over time. What matters is consistency. What matters is what your body is communicating across days and weeks, not what one startled glance at the monitor told you on a Tuesday morning after poor sleep and a rushed start. Medications like amlodipine, Losartan, and lisinopril should be evaluated by trends, not reactive panic. Diane was 67 and reached for her blood pressure cuff every time she felt unsettled. A headache sent her to check. A stressful news story sent her to check. A high reading triggered another check 2 minutes later, then another, until she had accumulated a page of numbers and a heart full of dread. She was convinced her lisinopril had stopped working. But when we introduced structure, consistent timing, quiet rest before measuring, the same conditions each time, an entirely different picture emerged. Her medication was performing reasonably well. The chaos was in the measurement method, not the medicine. Good medication paired with poor interpretation produces poor outcomes every single time. Number 2 is about consistency, and I cannot emphasize strongly enough how frequently this produces unnecessary danger. These medications work best when taken at a consistent time, within a stable routine. If you miss a dose, the answer is almost never to double up later, unless a clinician has given you very specific instructions to do otherwise. Most guidance for these drugs advises taking the missed dose when you remember, unless you are already close to the time of the next scheduled dose, in which case skip it entirely and resume the normal schedule. Do not take 2 doses at once. Yet this happens constantly, because people are frightened of their pressure rising. Then they experience dizziness, weakness, or alarm from a drop they themselves created. Consistency is not a trivial detail. Consistency is what transforms a prescription into a stable, functioning treatment plan rather than a daily gamble. Martin was 75 and took his medication faithfully, except when he did not. If he forgot his lisinopril in the morning, he took it at lunch. If he then remembered before dinner, he would convince himself a second tablet was the safer choice. Once, after a high home reading alarmed him, he took an extra dose to protect himself from a stroke overnight. That decision left him spent and unsteady the following day. He had not failed through recklessness. He had failed because no one had firmly established for him that blood pressure medications are not emergency rescue tools for isolated spikes. They are long-game drugs. They work through steady, uninterrupted use, not emotional reactions to a single number. If you are uncertain what to do when you miss a dose, ask. If you are unsure about timing or combining doses, ask. Guessing feels inconsequential in the moment and can create very serious consequences shortly after. And now we arrive at number 1, the most important thing clinicians often leave unspoken. The best blood pressure medication is not the one that produces the most impressive number for 3 weeks. It is the one you can remain on safely, consistently, and with full understanding, because it fits your body, your symptoms, your other health conditions, your lab results, and your actual life. That is the truth that gets missed. A blood pressure medication can appear successful in a chart while failing completely in the real world, because you are miserable on it, you do not recognize its warning signs, or you have quietly begun avoiding it without telling anyone. Amlodipine can work magnificently for one person and cause debilitating swelling for another. Lisinopril can protect the kidneys and manage pressure beautifully, while a dry, persistent cough destroys sleep quality. Losartan may be an excellent alternative, but it still demands vigilance around potassium, kidney function, and hydration. Let me close with Teresa, because her story ties everything together. Teresa was 70 with excellent blood pressure numbers on lisinopril. Any clinician reviewing her chart would have been satisfied. But Teresa was coughing through every night, sleeping miserably, and beginning to dread taking the pill. She said nothing to anyone, because she assumed the response would be, "You need it, so you simply have to tolerate it." That assumption is where patients disappear. First, they resent the medication. Then they begin forgetting it intentionally. Then they stop it entirely. Then the blood pressure climbs again, and everyone is confused about why. Teresa did not need a lecture. She needed a treatment plan that actually fit her. Once the cough was identified as medication-related, her clinician was able to reassess and adjust. That is genuine care. Not push through at all costs, not suffer silently because the number on the chart looks acceptable. Real care means the person matters as much as the pressure reading. Here is what physicians do not always say clearly enough. Side effects are not personal failure. They are data. Swelling is data. A cough is data. Dizziness is data. Weakness following dehydration is data. An unusual heartbeat, lingering lightheadedness, worsening fatigue, muscle cramping when potassium is drifting, all of it is information. Your responsibility is not to diagnose yourself. Your responsibility is to notice the pattern and communicate it. Too many people believe that being a cooperative patient means never raising concerns. That is exactly wrong. A good patient pays attention. A good patient speaks up early. A good patient does not wait until their throat is closing, their kidneys are struggling, or their blood pressure is uncontrolled because they quietly stopped the medication 3 weeks ago without telling a soul. Silence is not strength here. Silence is risk, and risk compounds in the absence of information. Here is the practical framework I want you to carry forward. If you take amlodipine, watch for ankle swelling, facial flushing, headaches, dizziness, and that heavy leg sensation that builds as the day progresses. If you take lisinopril, watch for a persistent dry cough, dizziness, and any swelling involving the lips, tongue, or throat. If you take losartan, watch for dizziness, unexplained weakness, illness-related fluid loss, and signs that potassium may be rising, such as muscle weakness, cramping, pins and needles, or an irregular heartbeat. With losartan and lisinopril particularly, blood work matters consistently. With all three, regularity of dosing matters, and with every single one of them, a symptom you cannot explain is worth discussing with your care team. You do not need certainty to make that call, you only need a pattern that concerns you. One more thing before we close. Not every side effect signals catastrophe. A mild headache when beginning amlodipine may resolve on its own. Mild dizziness when blood pressure first drops may ease as your body adapts. A dry cough on lisinopril can be disruptive without being dangerous. But not every side effect should simply be endured indefinitely either. There is a meaningful difference between "this may improve within a few days" and "this is eroding my quality of life." Patients routinely blur those lines, either panicking over something manageable or minimizing something serious. The answer is neither panic nor denial. The answer is informed interpretation. And interpretation sharpens considerably when you understand the class of drug you are taking, how it operates inside the body, and which signals cross the line from inconvenience to urgency. Consider how many people are living with blood pressure medication in a fog of partial knowledge. They know the name, they know the dose, they know they have to take it, but they do not understand why the ankle swelled, why the cough appeared, why the lab values shifted, why their doctor asked about ibuprofen, why dehydration suddenly became relevant, or why a salt substitute could become dangerous. That fog generates fear, and fear generates poor decisions. The moment you genuinely understand the mechanism, the fear largely dissolves. You stop catastrophizing every symptom. You stop pretending that obvious symptoms mean nothing. That balance is precisely where safety lives, not in ignorance, not in obsession, but in understanding. And once you understand, you become considerably harder to harm, because you stop being passive in the presence of powerful medications. If this has been useful to you, share it with someone who is currently taking blood pressure medication, because there is a strong likelihood they need this information too. I will be here in the next video, helping you understand the health realities that matter before they become the emergencies you never saw coming. That is exactly why this channel exists. I am Dr. Michonne. Take care of yourself, and start by understanding what you are taking.